Good evening, everyone. This is Meldita and I'm back. I promised before that I will be talking about ventricular tachycardia and SVT, but I changed my mind because we will be focusing on ventricular tachycardia. VT is actually the initial for ventricular tachycardia. Ventricular tachycardia is a wide complex rhythm. It's fast, and it's coming from both ventricles. It's either one, of course. And it could be 3 or more consecutive PVCs, or the so-called short-run VTAC or the long-run VTAC. The QRS of VTAC is more than 0.12 seconds. The rate is 110 to 250 beats per minute. It depends on your reference. The forms of VTAC, it could be associated with structural heart disease problem, example, myocardial infarction, where there is an infarct or dead tissue that creates a substrate for VTAC. Dilated cardiomyopathy, where there is fibrosis, and arrhythmogenic cardiomyopathy, where the fatty tissue replaces the ventricular cells, healthy cells. And also, it could be that VTAC can happen, in normal heart anatomy, but if you do MRI checks or closer look, there are some tissues that are having problems, and they will create VTAC. Or it could happen in normal heart, actually, but mainly the problem there is more electrolyte depletions. Okay? And we have those fascicular ventricular tachycardia, outflow tract, left ventricular outflow tract. They also fall under the normal heart anatomy, but closer look, there are some electrical issues involved. Well, VTAC could be also monomorphic or polymorphic. When you say monomorphic VTAC, the VTAC is coming from one focus, and you see the QRSs are all uniform. Example of that is the monomorphic VTAC right here. I got an example. In one lead, they're all alike. Okay, you could either go to V2 or V1, but they're all alike in one lead. Okay, it could also be polymorphic. When you say polymorphic, the VTAC is coming from many foci or from different origins, and the QRSs are not uniform, so they vary. And I'll give you an example of that. We have here the polymorphic VTAC. So you see the QRSs here, they vary. Okay, next. This VTAC could be non-sustained or sustained. When you say non-sustained VTAC, okay, it's self-terminating. It's actually less than 30 seconds. No problem to the patient, but it's self-terminating as mentioned earlier. When you say sustained, it's longer, and it's more than 30 seconds. And this sustained VTAC can manifest signs and symptoms. So the patient can verbalize palpitation, chest pain, they could be short of breath, low blood pressure. Some will be dizzy, lightheaded, or decreasing level of consciousness. They can syncopize or go into syncope, or the bad part is cardiac arrest. But not all of our patients will go to this cardiac arrest. It depends on what kind of ventricular tachycardia they have and which part of the ventricle. Is it the right or the left? Another one is the mechanism of the VTAC. It could be reentry. For people that have a heart attack, they can create a substrate, and actually electrical impulses cannot pass through, so they go around it and create a loop. It could be automaticity. This usually happens along the conduction system, but sometimes if the conduction system is also infarcted, no choice, there could be some automaticity coming from the ventricle cells. Okay, triggered activity. Usually this action potential or impulses or beat will happen after depolarization, right here. So we have also an action potential happening right halfway of the T wave. That is an R on T phenomenon. And you call this the early after depolarization. This kind of VTAC happens halfway of the T wave, and that's not good. It can create a chain reaction of VTAC in here. And usually like long QTs, low potassium, low magnesium. Okay. And we have also a beat or action potential that happens on the automaticity part, and this is called the delayed after depolarization VTAC. right here on the automaticity, just before the start of a new beat, they will go first. Okay, so that's the delayed after depolarization VTAC right here. So this VTAC comes earlier. The other one, T wave. So the VTAC will come, whoever is stronger will be the one to start, doing, this is actually close to finishing the repolarization, is starting to create to conduct an impulse in here. As long as it is strong, VTAC is stronger because it's only halfway, so it's already there. So that is called the delayed after. This is the early after depolarization. That is an R on T phenomenon. The R wave of the VTAC and the T wave of the patient's own rhythm. So that one, and could be low potassium, low magnesium, long QTCs or prolonged QTCs. Okay, and this one is actually delayed after depolarization. Okay, so when you say reentry, there's so in reentry, once a part is infarcted, that is an infarct-related ventricular tachycardia. Okay, and for some, like the right ventricular outflow tract, it's either they start from the left or from the right ventricle. They are reentrant ventricular tachycardia. Okay, so some of the VTAC diagnosis criteria. So how will you be able to know whether that rhythm is not SVT, but it's actually VTAC? Well, there are some things to think about. Like for instance, in one lead fusion beat, capture beats, we have concordance, AV dissociation, the bundle branch blocks. We have axis, but usually axis is not much of use. Okay, but anyway, we'll discuss one item at a time here. So let's take a look at the fusion beat. If I see a ventricular tachycardia like this, okay, you look closer at it, and let's focus first on the fusion beat. Okay, this is a wide complex tachycardia. Fusion beat, do we have a fusion beat? Of course. There is one in here that's quite different. This is a lead 2. They are quite different. If you look closer, it's smaller, and the next one is smaller. So because I don't have a 12-lead ECG to compare this VTAC ECG, so it could either be a fusion or capture beat. But because it's small, it's a fusion beat. But for some leads, actually, they look larger. So this one, it happens is smaller. So as I said, I have no comparison with this patient's previous ECG 12 leads here. Okay, so that's either fusion or capture beat. When you say concordance, the concordance is when all when doing a VTAC reading, you don't look at the lymph leads. You actually look at the precordial leads from V1 to V6. So V1 to V6, concordance. Are they all going to the same direction like this one here? Okay, in V1, it is downward. So we have a left bundle pattern. Okay, from B1, B2, B3, B4, and B5. But look at this. So now this is different. So the criteria for doing a VTAC, if you don't have a concordance, actually you go, is it SVT with a right bundle, or it is a VTAC? Or is it SVT with a left bundle, or VTAC? Now, because we have a left bundle pattern, so let's take a look at this VTAC here with a negative deflection.